Good afternoon. Good afternoon. It's Dr. Velma Scanterbury here, coming to you live from Dialysis Patient Education, Kidney Citizens, and we are here to answer your questions. I am here to answer your questions. Today is Wednesday, July 5th, and it's the day after the 4th of July, and I hope many of you have had a wonderful day. Yesterday, it was raining some places and beautiful in some others. And so I hope today you are, for those of you on dialysis, some of you may be there being dialyzed, have had your dialysis already, or maybe going in later on. And hope everyone was able to enjoy a wonderful day. Unfortunately, whenever we have holidays, we tend to indulge a little too much, and we want to make sure that we be a little bit more careful the rest of the week, considering what we have had to eat and what we've had to drink over the past couple of days. Many of you have taken Monday off and had a very, very long weekend. So either you're back to work today or you're at home resting and enjoying the day. So again, I am Dr. Velma Scanterbury, and I'm here to answer all your questions regarding patients on dialysis, getting on the transplant list. If you've had a kidney transplant, drop a comment in the chat as to how long you've had your transplant and how you're doing. We love to hear if you've had any issues, and also if for those of you who are on the transplant list, what issues are you facing? Have you been called for a transplant? Many patients are disappointed because we know that the waiting list is long, and there are thousands of patients waiting for a kidney transplant. And so it's important to understand that you may get called, and the time that you get called in for that transplant, it may not work out because you may be, the patient ahead of you might have gotten it and you were just as a backup, but that's okay. Or the kidney may not have been okay. The doctors might have decided that I'm going to pass on this one based on the anatomy or based on some biopsy that they saw at the time that the kidney arrived at the hospital. So there's also some information that you don't know as a physician accepting the kidney until the kidney arrived. And then we're able to look at it and see if it's acceptable for that patient. And so some of those decisions are told about the patient, and that it may be 3, 4, 5 times that you may be called to before you actually get a transplant. So that's okay. I see one person said they've had the transplant for 12 years and are doing well with a creatinine of 1.2. So congratulations to you. That's very exciting. I also understand that for some people, kidneys don't last forever. You remember, unless you have an identical twin, that kidney, your body will see that kidney as something foreign. And the reason for why you need to take immunosuppression or anti-rejection medicine is so that kidney will be not attacked and destroyed by the body in its immune system. So if you have an identical twin, then your genetic makeup is the same as that person's, and so it becomes important that if everyone else will need to take anti-rejection medicine, and so the medicine is there to, how I describe it, to cloak your kidney, so your kidney's immune system isn't going to recognize that kidney as foreign. And so you need that medicines every day in order to keep that kidney alive and to keep it protected. But sometimes, I tell folks, kidneys are like cars. You can get a new car and have it last for many, many years, or you can get a new car and have that car not last but 2 or 3 years or 4 or 5 years because it was a lemon, or it got into multiple accidents, and therefore the longevity of it was compromised. But you can also get a used car and everything goes well, and despite being a used car, it still lasts you 10, 12, 15 years. So those are the things we face when we think about kidneys and the longevity of kidneys. We want to know what condition it's in. We biopsy it before. We want to determine for this person is this kidney going to last them a long time? Certainly, if you're older, in your late 60s or 70s, we're not going to look for the same kind of longevity. We just, in that kidney, we just want to hopefully get you through 5 or 10 years or more, if so, because your demands of your body for that kidney may not be the same as a 20-year-old who may need 2 or 3 transplants or even 4 to live to be an adult of 60 years old or older, even older than that. So we want to be, what we would offer or be willing to accept for someone who's a teenager or in the 20s or 30s is different than what we would accept for someone in their 60s. So that makes a difference. And it also makes a difference in terms of patients who have donors that are older. So if you are in your 40s and 50s, certainly, if your parents are older in their 70s, they may not qualify as donors to take that kidney, not because they can't, but because that kidney may not give you enough longevity for that kidney, for your size and the age of that kidney. And 2, making sure that your parent, who may be in their late 60s, I don't think anyone would take in the 70s, in the late 60s may be in jeopardy by taking away one of their kidneys, and that their remaining kidney may not last as a single kidney for the rest of their life. So it's also about making sure that we don't jeopardize the life of the longevity of the remaining kidney in the person who's the donor. So it's important that someone be able to donate even as a living donor, but leaving them with adequate kidney function so that there's no predictable insight into whether or not they will be needing a kidney transplant in 10 years at a time that they may not be qualified to be a kidney recipient. So those things are important when it comes to understanding how we choose donors and how we choose recipients. One person just said, I just received a kidney on May 28th, and I'm at home recovering, and everything is doing well. Congratulations to you. How exciting to be able to receive a new kidney. That is awesome. A true blessing and a true gift from that donor family, whether it was a living donor, deceased donor, someone gave of themselves to be able to get you off of dialysis or to keep you from being off of dialysis. And that is fantastic. Congratulations to you again. Take care of that kidney. Remember, that's your lifeline, because once you have good kidney function, your heart works better and you're able to control all that fluid balance is absolutely now in the hands of that kidney. And you know that heart disease for patients on dialysis is always ongoing. And so it's important to understand that certainly with a new kidney, you can now get all that extra fluid is able to be better regulated and be able to get your heart to rest a little bit more. So now your heart volume is able to be better controlled, and that is so fantastic, because with a kidney transplant, if you didn't have heart disease before you end up with kidney disease, just kidney disease in itself is going to cause you to develop heart disease because of the fluid balance and the high blood pressure that can be a cause of your end-stage kidney disease. And so getting back to normal with the normal kidney function is fantastic. Another patient just said, I just celebrated 27 years as a living kidney donor. Awesome, awesome, awesome. Congratulations to you in being able to help someone else and donate your kidney to the life of someone, to allow them to also have a fantastic leash in life. And being a living donor is absolutely phenomenal, because not everyone is willing to be a living donor. Not everyone can be a living donor, because our goal is to make sure that you're in good health. We're not going to take you as a living donor if there's issues that we can predictably see for you moving forward as a living donor. We want to make sure that you have 2 kidneys and that you can donate 1, because if you have 1, you need to keep that 1. You're not able to give that up. And 2, we want to make sure your heart's in good condition. We want to make sure you, as a potential donor, have no underlying problems that would lead you to develop kidney disease down the line. Not as long as we can able to predict it. There's things that happen that we have no control over. We don't have a crystal ball. So that's why if you're a diabetic and you're thinking about donating, you cannot be a donor, because diabetes is the number one cause of end-stage kidney disease. High blood pressure used to be an absolute rule out, but now if you have high blood pressure on one or two medications and you are a close relative of the donor, of the recipient, then you can be allowed to be a living donor. If you're Caucasian, if you're African American, there are some questions, and most programs will be reluctant to take you as an African American with high blood pressure on medication, because your risk of kidney disease is so much higher as an African American, going on from chronic kidney disease to end-stage renal disease. So that is very important to understand. So thank you for all the living donors out there. Another question is, does someone with end-stage renal disease on dialysis automatically get heart disease? No, it is about controlling your fluid balance. Certainly it's a majority for patients on hemodialysis, I should say, because that's where the fluid balances are much more difficult to control, especially once your urine volume has ceased. So if you want peritoneal dialysis, you have better control of your fluid volumes. You're able to still urinate. From many patients, the majority of them may still be able to urinate on peritoneal dialysis, and so you have that ability to control your volume, and so that is certainly a plus. Home dialysis or frequent dialysis also decreases your risk of heart disease, because you're not accumulating enough fluid that if you're dialyzed 3 days a week, you're holding on to that extra fluid and not being able to get rid of it until the third day or every other day. And so just imagine your heart, if you gain 10 pounds or 10 pounds, 5 kilos, you're thinking that's not much, 7 kilos, but think about that in terms of pounds, and how much weight that your heart is now having to hold. And so gradually you can get wearing out of your heart because of the volume on and off. So I said, people, think of your heart as a accordion, and it expands as you gain that fluid and decreases as you take it off. You gain it in 3 days, you take it off in 4 hours. And so that can cause wear and tear on your heart. It can cause decrease in the elasticity of your heart. And it's important. Phosphorus control, as much as we think about it mostly in terms of diet, the more you are out of balance with your phosphorus, the more you develop atherosclerosis. And so the more plaque disease and hardening of your arteries, your coronary arteries, can occur because of uncontrolled phosphorus. So that's very important. That the calcium phosphorus balance is very important for underlying health of your blood vessels, leading to cardiovascular health. And we will see patients whose phosphorus is not controlled develop severe plaque disease in a few years. So that is also a factor when you think about controlling your diet and what you're restricted on in terms of longevity. So it's about keeping your volume down, minimizing your weight gain, not stressing your heart out, keeping your blood pressure under control, and making sure that you get regular tested for your underlying heart, especially if you're past 5 years and 8 years on dialysis. Then you want to be able to make sure if you're on a transplant list, you're getting your heart tested over time, because we will usually get a stress test and a echocardiogram on an annual basis. If you're not on the transplant list, that can be a limiting factor. So if nothing else, you want to make sure that your cardiovascular health while you're on dialysis, once you get past year 3, is being monitored very closely, especially if your older population of older age have underlying heart disease based on years of high blood pressure and years of dialysis and years of diabetes. Those two underlying causes of end-stage kidney disease can accelerate your underlying heart disease. So, there's so many factors that go into that. So definitely peritoneal dialysis is much better in terms of the homeostasis of your heart and regulating volume. And daily dialysis, home dialysis, keeps your balance, much more in order than in-center dialysis, and decrease your overall risk of more strain on your heart. And so that's also something to consider, and certainly keeping up with your dietary restrictions from that standpoint. I'm waiting for a kidney. The process seems very slow, trying to get it done before I get on dialysis. That's certainly the best way, if you're not on dialysis, is to think about who's out there that can donate a kidney to you. And if you have a living donor, then you can go ahead and get that workup completed, have your living donor have their workup completed, and potentially plan that transplant before you even need to hit dialysis. When your nephrologist says, now it's time for some kind of renal replacement therapy. And so we have patients who are worked up for, and in the meantime, you get on the list. So as long as you don't have things that are barriers, or for some patients who are not on dialysis, if they need a cardiac catheterization, which involves dye, we know that dye load can often tip you over to dialysis. So we may wait just before the time that you need to be dialyzed, or try to minimize the number and the amount of dye that you need, because that can be hard on your kidney. So oftentimes there are things that may hold you up, but if you're getting on the deceased transplant list, you want to work with your coordinator, see if you can get all your tests completed in a timely manner and get listed. But if you're just getting listed, and depending on where you live, it's unlikely that you will get called for a deceased donor kidney, because you haven't accumulated a lot of time. And generally based on blood type, if you're blood type O, you're going to wait unless you are in a city where there's a lot of donors and the waiting time is short. But basically, to get it, if you have a living donor, that's the best way to go. And I hope you can look into that to research that. I donated to my mom in 1996 at UCLA. Thank you so much. Congratulations to you for being wanting to help your mom get off dialysis, or to not even begin to. So congratulations to you. Thank you for donating. And we want to be able to for you to know that as a donor, it's also important that you can that you follow that single kidney. You now have one kidney, and a certain amount of people are born with one kidney. It doesn't necessarily put you at risk for kidney disease unless you develop high blood pressure and diabetes, but it's not a predictable event. So certainly, whether you develop diabetes or high blood pressure, you want to make sure that you're closely monitored, because it affects whether you had one kidney or two kidneys. Is not going to limit your ability to do that. So you want to make sure your lifestyle adjustments, that you make sure you're following your creatinine of that single kidney, making sure that you also monitor your urine to make sure there's no protein in your urine. So that's very important. Another question is, do all transplant recipients get diabetes? No, not all transplant patients. There are some patients who have a higher risk of getting diabetes because of the genetic makeup. We know that there's some HLA genetic information that puts some patients more at risk for diabetes, but about 10 to 15% of the patients, based on the immunosuppression, will put them at risk for diabetes. So many programs now are beginning to eliminate the use of prednisone long-term after the transplant, because it's also one of the medications that helps prevent rejection, especially early on. But if we can come up with a cocktail that allows you to do well and not develop rejection without steroids or prednisone, that will be the preferred route. But some patients have underlying issues that will make it not possible. If they come to transplants with a high antibody level, and are more likely to face rejection, then we will be a little careful about avoiding prednisone, because your risk of rejection may be higher. If you've had underlying diseases that require prednisone to keep your disease quiescent, like lupus or sarcoid or other autoimmune diseases, you may not be a candidate to go without steroids after your transplant. Even the whether it's cyclosporin or tacrolimus, there's still a slightly incidence of diabetes with both of these main immunosuppressive agents. And so we do follow patients. For many patients, when they have diabetes on dialysis, unfortunately, because they're on dialysis, their insulin levels will go down because the use of insulin, because insulin is excreted by the kidneys. And so for many diabetics, they make a small amount of insulin, but because they're not urinating, that insulin stays in their body and they don't need to take additional insulin. So while they're on dialysis, they say, I'm no longer diabetic. But yes, you're diabetic. You're just not able to pass out the metabolites of insulin. So once they get a kidney transplant, now they're able to urinate out that insulin. They require insulin again. So if you have diabetes before your transplant, you're likely going to continue to be diabetic due to the lack of your body not making enough insulin after the transplant. And now the use of insulin will need to return. So that's a little confusing for patients to understand from that standpoint. Teresa, yes, we can see your comments. Thank you so much. You have been blessed. I received my second kidney transplant on February 26, 2019. Congratulations to you. You had to receive 2 kidneys. Probably one's on the right side and one's on the left side. But congratulations to you who have been able to have 2 kidney transplants. Sometimes we ask patients, people ask, well, how many transplants can someone receive? Well, I've done probably only one patient with number 5 transplant. There are less numbers, there are less people receiving the 4th transplant than the 3rd transplant. I've done quite a few of number 3 transplants and probably less than half a dozen transplant number 4. So I really understand the need for a repeat transplant. Some patients do very poorly with rejection and therefore need to have a second transplant. Oftentimes patients may get a kidney that just doesn't jumpstart, and that first kidney may not do well. Or they can have a first kidney who does absolutely well, but lasts about 10, 12 years, and then they need a transplant. So those things do happen. Not meeting adequacy on PD. My team has me on isodextrin in my last fill because of absorption issues. And that can be seen after being on PD. The lining of your peritoneal lining gets very thickened, and so you're unable to have those adequate exchanges. And so that's very unfortunate because for many people, they would need to switch over to another form of dialysis replacement, such as hemo. So I hope they're able to resolve your issues for you. So thank you so much. One other question I have, PKD, will they need to remove my kidneys before transplant? Not really. Many patients have PKD, and depending on the size of the kidneys, depending on how tall they are, generally, as I would lay a patient flat, and will like to see if the native kidneys protrude beyond the iliac crest on the side, and that is your hip bone. If they're higher than that, you're okay. If they're deep in your pelvis, generally your liver pushes down your right kidney a little bit more than your left kidney. Oftentimes with patients where they may have cysts of that polycystic kidney disease that is ascending deep into the pelvis below the hip bone on the right side, we're still able to put that kidney on the left side, which may have more room on the left. So we try not to, because it's a very big operation to take out your native kidneys. Oftentimes we started doing it at the time of the transplant. It can be very messy, requires a whole new incision. So we think it's better if you need to do it before. So very few patients I've had a need to do it before, have just gone ahead and placed a new kidney in there. So thank you so much for that question. Yes, I am a 2-time transplant recipient. I do not know. The second one was from someone I do not know. I'm blessed. First one lasts about 10 years. The second one for 4 years. So congratulations to you. Like I said, oftentimes we don't know, you may get very good length out of the first kidney, and for many patients, there really is no prediction. And while you're a transplant patient and we see your creatinine is getting worse, oftentimes it's important to predict whether or not you will need to be on dialysis in a year or two, or whether even before you get to dialysis, if we can get you back on the transplant list so that you can begin accumulating wait time for your second transplant, if it's going to be a deceased donor transplant as opposed to a living donor, so that while you're on there, you can still be off dialysis but accumulating points as you wait for your second kidney. Sometimes patients come up for a kidney transplant, get called for a kidney, and they're not quite there, and the kidney may not be that much better than what their present function is, and so we may decline that kidney. So thank you so much. My point in posting, my blessing, never give up. Thank you, Teresa, for that. Never give up, because we don't know what's coming down the pipeline. Oftentimes I tell people, try to, not just you, but you and your family can be advocates for your health. You can advocate for those who may not know they have kidney disease. And oftentimes your story may help someone else understand that they may be at risk for kidney disease because they've had diabetes for a long time. Maybe they're having more swelling in the ankle and the kidney function is failing. Just bringing your story to the awareness of others can help others understand that, yes, there are thousands of patients with kidney disease and don't know it. And so it's very important to help others if you can understand that it's not a death sentence. There are options. There are things that you can do to improve your health. There are things that you can do to delay dialysis. And there are things that you can do to improve your high blood pressure, get your diabetes under control, and understand that there may be others in your family who may be at risk for kidney disease. And sharing that information allows you to be able to do that. So, Teresa, I'm going to thank you for being here. Any last questions? I think there was a question initially about phosphorus in your diet that I failed to answer. Let me see. When should I take my phosphorus med, before or after your meals? You really, follow the directions of your nephrologist. You want to make sure that you have your binders in your system, I would say before, so that you can bind your food that are high in phosphorus. You also want to avoid foods that are high in phosphorus, and that's important to do so because especially as we go into the summer, you're tempted to eat that ice cream, that cheeseburger, things that may add more phosphorus in your diet because it's that season, you're out and about. But think about taking your binders with you as you travel, as you may not be home, and that you have those things right with you to be able to take them while you're out, because controlling that phosphorus is crucial to your underlying cardiovascular health. And it's not dialyzed, and so you can't fix it by having dialysis. It's just going to be based on what you're eating and taking your binders. And I know they're difficult to take. They taste terrible. No one wants to be taking these amounts of pills. But yes, that's a tough one, but it's your lifeline. And I want you to think of it as that, because your cardiovascular health is certainly related to your phosphorus and your fluid volume. So this has been a great conversation. I want to thank you, Teresa. I've been trying to get you on here. I think you're finally on. I can't see your face, but I think I can see part of you. So thank you so much for all of you. It's 1 o'clock. I appreciate all of you hanging around to have this very robust conversation, asking all your wonderful questions. It was great talking about all these various topics. I appreciate all of you being here, and we'll see you in 2 weeks. Actually, in a month, we have a Facebook Live in 2 weeks under dialysis patient citizens. Also, you can feel free to come on there, invite your friends, and let's keep that conversation going. Ask your questions, keep your questions, and even those in your family members may have questions about you as the patient, how to better take care of you, how to advocate for you, how they can be a donor advocate in terms of being the person out there helping you find that donor. So I appreciate that. Have a wonderful day, and enjoy the rest of the week. Stay cool. Limit your fluid volume, keep up with your dialysis treatments, and watch that phosphorus, as we tend to want to eat that ice cream as we're out there doing that. So have a wonderful day. Take care and be blessed.